Good morning, everyone. I am Luca Arecco. I'm a medical oncology resident from the University of Genova and the Policlinico San Martino Hospital in Genova, Italy, and also a research fellow at the Institut Jules Bordet in Brussels, Belgium. And at DESMO 2024, we will present at Monday 16th a poster dissecting the prognosis of patients with hormone receptor-positive HER2-negative early breast cancer according to the monarchE and NATALEE trial risk categories. This is a patient-level analysis of Mammella Intergruppo and Gruppo Italiano Mammella randomized trials. As a background, we know that CDK4/6 inhibitors in association with the adjuvant endocrine therapy have proven to improve the outcomes of patients at high risk of recurrence, both in the monarchE and the NATALEE trials. However, monarchE and NATALEE trials apply different inclusion criteria to define patients at high risk of recurrence. In particular, monarchE trial included only patients with no positive disease, so really at high risk of recurrence, while for NATALEE trial, they also included a broader range of tumors, including patients with no negative disease. Our analysis wanted to include individual patient-level data from patients diagnosed with hormone receptor-positive HER2-negative early breast cancer enrolled in 3 adjuvant phase 3 trials conducted by the MIG and GIB study group, basically the MIG-1, GIM-2, and GIM-3 trials. And the main objective of our analysis were to divide the patients in 3 different cohorts according to the inclusion criteria of the NATALEE and monarchE trials. Patients have been divided in concordant non-high-risk cohort, so patients at non-high risk for both trials, concordant high-risk cohort, so patients at high risk of recurrence for both trials, and finally discordant high-risk cohort, so patients considered at high risk of recurrence for only one trial, but not for the other. Going to the results, we have included in the 3 randomized trials almost 7,000 patients that have been randomized in the MIG-1, GIM-2, and GIM-3 trials. And after applying the main inclusion and exclusion criteria, 4,795 patients have been included in our analysis. And if we look at these 4,795 patients, they have been divided in the 3 cohorts, being 28% of the patients classified in the concordant high-risk cohort, so had high risk for both trial, monarchE and NATALEE, 43.9% of the patients classified as concordant non-high-risk cohort, so at non-high risk for both trials, while we had a 28.1%, meaning 1,346 patients that were classified in the discordant high-risk cohort, meaning those patients that were at high risk for one trial, but not for the other. And if we look at the results in terms of 7-year disease-free survival, the 7-year disease-free survival was 69% in the concordant high-risk cohort, 84% in the discordant high-risk cohort, and 89% in the concordant non-high-risk cohort, meaning a delta in 7-year disease-free survival of 5% between the discordant high-risk cohort and the concordant non-high-risk cohort, against a 20% in 7-year disease-free survival difference between the concordant high-risk cohort and the concordant non-high-risk cohort. But if we look at the overall survival, the 7-year overall survival was 84% in the concordant high-risk cohort, 95% in the discordant high-risk cohort, and 96% in the concordant non-high-risk cohort, meaning that we have a delta of 12% between the concordant high-risk cohort and concordant non-high-risk cohort in 7-year overall survival, while only a delta of 1% between the discordant high-risk cohort and concordant non-high-risk cohort in 7-year overall survival. So in conclusion, patients at high risk according to NATALEE trial, but not included in the monarchE trials, seems to have a slightly worse prognosis compared to patients that are considered at a non-high risk for both trials, meaning in a delta of 5% in 7-year disease-free survival and a delta of 1% in 7-year overall survival. All these differences, also of small magnitude, were statistically significant. However, we think that these results may help physicians and patients to perform more informed discussion on the need to escalate the adjuvant endocrine therapy based on the baseline risk of recurrence of our patients. And I would like to thank the OncoAlert network for the kind invitation.